My presentation title today is the research stratification of MASLD-associate HCC. This is the outline of my talk. The first one, I will give a short introduction of MASLD-HCC, and the second will be the research stratification of fibrosis stage and also the HCC prediction score. First, I will talk about the natural history of MASLD. As we know, the disease progress of the liver disease progress from the muscle simple steatosis and the MASH steatotic hepatitis and to the early fibrosis. At this stage, if the patient has adequate management, the disease may be reversed from the early fibrosis to the MASH or even to the simple steatosis in some proportions of patients. However, if the patient progress to the advanced fibrosis or even to the cirrhosis, the disease may be progression worsening. And about the HCC index for the MASLD, the annual incidence is about 0.5 to 30% according to the different studies. So if the patient received adequate treatment and the progression from muscle to MASH to the cirrhosis was maybe a process that is significant dynamic and bidirectional. The risk factor of MASLD progression may include many factors that include type 2 diabetes and visceral obesity. These two risk factors are most important among the factors. The other include gut dysbiosis and unhealthy diet, alcohol consumption, and also the genetic background predispositions. So the disease progression of MASLD is very complex and multifactorial. So in addition to the so-called traditional risk factors, such as I mentioned, in Asia, there's another risk factor should be mentioned. In this study from the Hong Kong, they found that when the patients are present with NAFLD and the positive hepatitis B core antibody, there's an increased risk of the liver-related event when compared to the only NAFLD patients. So in Taiwan, it's a HBV endemic area. So patients may be present with non-B, non-C. However, most of patients may be 70% of patients may age more than 40 years old. They had a higher chance of the positive or HBV core antibody. So maybe this is a factor we should take into account. As we know, when from the hepatologist view, the fibrosis progression of the liver may predispose to the HCC risk. So when patient fibrosis stage from mild to moderate to advanced, even to the cirrhosis, the HCC risk is increasing. However, when we look at many studies, the NAFLD HCC case not always present with cirrhosis. There are about 40 to 50% of patients had the NAFLD HCC are not cirrhosis. So when we look at the disease progression, when patient with simple steatosis, the HCC incidence is very low. However, when we to the other end of the disease, cirrhosis, the HCC index may be very, very high. However, when patients present with fibrosis between the mild fibrosis to the advanced fibrosis, not cirrhosis, the HCC index may be undetermined and may depend on many factors, not only liver fibrosis. Next, I will talk about the risk stratification by fibrosis severity. By this category, we should find out some high-risk populations. So the first one, I will talk about why we need non-invasive test, NIT, for fibrosis assessment of MASLD. As we know, the fibrosis represents the most relevant prognosis factors in patients with MASH. However, as I previously mentioned, the fibrosis progression may be a consequence or another result of the multiple factor of the MASH. And the second, the liver biopsy is invasive, expensive, and it cannot be performed on a large population. So NIT may be a good tool to replace the liver biopsy to achieve to assess liver fibrosis in MASLD patients. There are many common non-invasive tests for fibrosis assessment of MASLD. In this table, I list 5 of them. The first 3 include fibrosis 4, that is called the FIB-4 score. The second, NAFLD fibrosis score, NFS. The third, the transient elastography with FibroScan. These first 3 methods that include a cutoff value with a dual, like lower cutoff and higher cutoff. The lower cutoff, the aim of this measure is to rule out advanced fibrosis and also rule in advanced fibrosis. There is a moderate to high accuracy. The last 2 is enhanced liver fibrosis ELF and the MRE elastography. These 2 methods that can be diagnosed of advanced fibrosis by a definite cutoff value. There is a higher accuracy to determine the fibrosis of the liver. However, when we use the dual cutoff strategy, such as higher and lower cutoff to measure the fibrosis stage, they may be 40 to 60% of patients may have intermediate results. So that is a great zone to determine the fibrosis. So to overcome these limitations of the dual cutoff strategy, maybe we can use the sequential or simultaneous approach in clinical practice. So this is the algorithm of the sequential use of NIT. As we know, that's a common thing in many lectures. So the step 1 is to identify patients with hepatic steatosis, even by the histology or by image. The second step is to do the non-invasive test. Usually, maybe the FIB-4 is the first one. When you use the FIB-4, we can categorize these patients into the lower, intermediate, and the high risk. If the FIB-4 less than 1.3, that's a low risk, we can follow annually or 2 years. And if the patient lies in the FIB-4 more than 2.67, that's referred to a high risk. That should refer to hepatology or to other evaluation. A substantial proportion of patients may lie in between the 1.3 and the 2.67. That is an intermediate result. So a second non-invasive test here should be used, either by the liver fibrosis, liver stiffness measurement, or by ELF. According to the different cutoff of the different methods, we can also subclassify this intermediate result of patient into the lower, intermediate, and high risk. For intermediate risk and high risk patient, these kind of patients should refer to hepatology for further evaluation. So by this sequential use, that goal should exclude the advanced fibrosis and refer patient at the risk of disease progression. And by this way, that is a cost-effective and efficient way to risk stratification. and also they can avoid unnecessary secondary care referral by 90% of patients, and also cost saving by 40% of the cost. However, by last year, AGA update also has some recommendation. This recommendation is focused on the FIB-4 less than 1.3. Because the previous lower risk patients that should regular follow-up. But in this recommendation, they incorporate metabolic trait into the fibrosis assessment. When patient presented with the FIB-4 less than 1.3, and no metabolic risk factor such as no DM or no other metabolic dysfunction, this kind of patient should follow only. And if the patient presents with the type 2 DM or other metabolic syndrome features, the second non-invasive test such as ELF, FibroScan or MRE should be used as a sequential. And further can categorize this kind of patient into the lower, intermediate, high risk. And if the patient lie in the intermediate or high risk, they should another evaluation such as liver biopsy or so on. So that's it's a fibrosis assessment. However, fibrosis assessment is not enough for MASLD HCC. So that's many predictive scoring systems for HCC were published in the literature. This is a summary for some scoring system to detect HCC that include the MRE MAST score or GARA score and so on. So I list the three of them because there are some data on the MASLD patients and specific for this kind of disease. The first one is the MASLD score, that's called the MSD score. MSD score that use the ALT and the MRE and MRI PDFF. There's a user equation that listed below. By this, the MAST score, they can accurate to identify those NASH patients with adverse liver outcomes, include liver transplantation, hepatoma, and the liver-related death. So if the MAST score lie in the low risk or intermediate or high risk, there's many other values shown in the tables. The second is a GARA score that includes some 5 factors, like the gender, age, ALT, alpha-fetoprotein, L3, LP, and the PVCAR3. When compared with the NASH control, patient presented with the NASH HCC, there's a high sensitivity and specificity when the optimal cutoff shows minus 1.3. And also when we compare with the patient's cirrhosis or non-cirrhosis patient, there's also high accuracy. In addition, there's one cutoff value can early diagnosis when the HCC present clinically. So when the cutoff shows minus 0.63, they have exceeded 200 days before the clinical HCC diagnosis. So GARA score is useful for the early diagnosis of HCC. The third is non-4D related HCC risk stratification, but this score only used on cirrhosis only. That includes about 7,000 patients from the VA system of USA. They included 7 predictors. That's include age, sex, BMI, diabetes, platelet count, and the serum albumin, and some component of FIB-4. So by this calculation, we can predict the patients are in low risk, medium risk, or high risk of HCC By this score, risk stratification can be used to inform patients for HCC surveillance and also identify high-risk patients. However, the MASLD HCC is caused by the multifactorial just mentioned. So the risk factor include the demographic comorbidities, environment factor, and the fibrosis stage, medications, and also genetic background. So currently, we may use the before fibrosis assessment, but it's not enough. So we include some clinical factors into the models, so we can do the regression model. However, maybe in the future, we can include all the possible predisposing factors into the the models. So maybe in the future, machine learning maybe play an important role to exactly or accurately to estimate the HCC risk by the lower, median, and the high, and to do the different clinical assessment. So this is a last slide. The risk stratification by sequential NITs for fibrosis is suggested in MASLD patients to identify at the risk of patients. However, for MASLD HCC patients, incorporation of all risk factors to predict, to do the predict scoring system for risk stratification, it is strongly needed and warrants for the investigation. Thank you for your attention.